This is Scott Becker, and thrilled to get a chance to visit with you today. We've got a magnificent panel on minimally invasive surgery, robotics, and the acceleration of programs. We've got three fantastic speakers talking about what health systems are doing to lower costs, improve outcomes, and make the most of robotics programs, Da Vinci robot programs, as well as minimally invasive surgery. We're joined today by Dr. Matthew Thompson, Associate Professor of Urology at Mayo Clinic. We're also joined by Kent Bishop, who is Dr. Kent Bishop, the President of Promedica Physicians and the Chief Medical Officer. Promedica, a magnificent Ohio-based health system. And we're finally joined by Chris Walker, the Vice President of Clinical Services at Sharp Memorial Hospital in San Diego, also a magnificent health system. We're going to start by asking each panelist to quickly introduce themselves and just tell us a little bit about their background, and then we'll go ahead and get into the details of sort of what they're doing, how programs are accelerating, what's working, what's going great, what's not, what they need to do. Dr. Bishop, let me ask you to take a moment to introduce yourself and tell us a little bit about what you're doing with robotics.
Sure. Happy to be here this morning. I am the Chief Medical Officer for our provider division and the president of our physician group, which is 1,200 providers. My career really in administration has really mirrored the growth of our robotics program. I'm an OBGYN by training, started doing robotic surgery in 2010, kind of grew my practice, and then kind of forayed into the administrative roles. So this has been a pet project of mine and something that's really near and dear to my heart because I think robotics and minimally invasive surgery as a whole really does provide the kind of outcomes and patient care model that I believe in and our organization believes in and has bought into.
Thank you very much. You come to this from an obstetrics gynecological background. Let me turn to Dr. Tollefson at Mayo Clinic, comes with some urology background. Dr. Tollefson, can you take a moment, introduce yourself, and tell us a little bit about robotics and how you got involved in robotics?
Yeah, of course. My name is Matthew Thompson. I'm a professor of urology at the Mayo Clinic. And I think I was fortunate to grow up in that era where robotics was really starting to expand and explode. And I've taken that clinically and I think been able to offer some unique experience in the context of urologic cancers. From an administrative side, I've also led our institutional goals and objectives in the robotic space and worked to continue to develop and innovate within our surgical practice. It's been an exciting time, and I think our company is really, or our corporation is really in alignment with some of the goals and objectives that we can accomplish with a robotic approach.
Thank you, Dr. Tollefson. You come from a urology background, Dr. Bishop from a gynecological background or OB-GYN. And Chris, let me ask you to talk a little bit about, you run service lines, Vice President of Service Lines at Sharp Memorial, great system. Tell us a bit about yourself and how you came to robotics.
Yeah, thanks, Scott. Glad to be here today. I actually came up the nursing route. Been in nursing for over 25 years, and I've been running service lines for the last several years, and particularly running the robotic service lines for our organization. So working on the strategy and advancement of our robotics. And we have 30 ORs here on our campus, and we have several robots. And part of my job is to help drive centers of excellence and recruitment of good physicians to practice and continue to grow.
Chris, thank you very, very much. Dr. Bishop, let me start with yourself. What's happened in the last several years, if we look at robotics, the Da Vinci robotic system and robotics generally, started a lot with gynecological surgery, urological surgery, and so forth. And now it's moved more into a more general service line. And that's probably reflected by Chris and what they're doing at Sharp Memorial. Dr. Bishop, can you take a moment and talk to us about the evolution from specific specialties to more of a robotics approach, a minimally invasive approach in general, and a service line approach? Dr. Bishop, any thoughts there?
Yeah, so I think the really important concept is, we, in almost every specialty, we really are looking to reduce open surgery. And I think, when you make the commitment to reduce open surgery, a lot of the specialties that have now evolved really couldn't move that. It was just a total laparoscopic approach. And with robotic surgery, we've actually seen tremendous strides in the number of open cases being reduced. And I think it starts with having a vision that reducing open surgery has to be the goal for your service line. And then when you think about, as a service line develops, in our system, if you don't put some structure around a program, then it doesn't remain sustainable. And so the key for us, I think, is to have that vision to reduce open surgery and to continue to have surgeons that in all walks and all specialties that want to reduce open surgery and improve outcome, and then put structure around those providers so that they can be successful. And then we can have a sustainable program that provides the outcomes that our patients deserve, no matter when they walk through our doors.
And Dr. Bishop, just one follow-up comment on that. The notion of trying to reduce open surgery now makes so much sense to all of us for so many reasons. But talk about when that became part of the vernacular, part of what you talked about, this movement away from open surgery to minimally invasive surgery. When did that become part of the goal or the core of what you try and do?
Yeah, I think it kind of mirrors the focus on length of stay and also the episodic care that we try to deliver when you think about value-based care. We need to put people back to work quicker. We need to have them return to normalcy quicker. And I think that was the initial goal. I think initially with the laparoscope, it was we just tried to develop and get better and try new things. And then we start to marry technology with, what are the true goals that a health system and a healthcare provider network can really deliver to employers and to the patients. And that just evolved. And I think the evolution of trying to improve that episode of care versus just what goes on in the OR has really, I think I'm proud of our professions, because our profession have really kind of looked at what they do as more than just what goes on inside those four walls. It goes into how that patient's cared for the rest of that episode.
Thank you very, very much. And Chris, a discussion from you on the evolution to a service line. Talk about the service line approach and how you look at things at Sharp and in your role.
Yeah, thank you. I really think it's not a service line. It's a collection of service lines. And I think it's going to be eventually every service line. And I think it all starts, just like Dr. Bishop said, it starts with a fundamental belief that minimally invasive is the way to go to reduce length of stay, to reduce complication, to reduce pain, and hopefully just deliver better care to our patients at a lower cost. I think another driver for us was physician transitions. You see a lot of physicians, almost every physician that comes out of any kind of fellowship training to start practice, they're all robotically trained. They all want to practice that way. Part of my goal is put the right tools and teams around our surgeons so that they can deliver the best care. And that's part of it. And then we also have a third of our population is a capitated health plan kind of model, which lower lengths of stay and member satisfaction are of the highest priorities for managing a strong health plan.
Thank you very, very much. And Dr. Tollefson, you're at Mayo Clinic. Talk about sort of investing in robotics, sort of ways to make acquisitions work, planned obsolescence, a few thoughts around sort of the economics of this and how you make this work and how you sell it internally to a system like Mayo. Talk a little bit about the robotic strategy and the acquisition strategy and so forth.
Yeah, I think, this is a really important point. And, I would say historically, Mayo is a Catholic hospital. So there are stories of nuns not giving surgeons certain equipment until the very last use. Episodes of where we've used retractors and things until really rust starts to take over. I think technology really changes that paradigm, and it really forces us to rethink these kind of historical, accepted, and recognized cost-saving measures to a different mindset where cost-saving could mean getting out of the hospital a little bit earlier. It could mean preventing an ICU stay. It could mean preventing a blood transfusion. So we've had a real shift in our mindset to understand the comprehensive cost of care and how we can invest in that to reduce the cost of care for the patients ultimately. I would also add that
robotics.
I would also add that.
But even though robotics may be an expensive. Go ahead, Dr. Tollefson. I'm sorry.
And I'd like to add that it's critically important to have strong governance and broad support around the acquisition and deployment of new robotic systems, whether one's using the AMP model or the more traditional purchasing agreements. This really is a hyper-local process, and understanding the goals and objectives of your individual robotic practice is just critical to informing these decisions. At Mayo, our case mix tends to skew a little more towards complex cancer surgeries within robotics. And we find that when we reach close to 300 cases per robot, it's time for us to start looking for additional machines. But that number can differ with each group and really is dependent upon the surgeons that you have and the case mix that you're doing robotically. But with appropriate foresight, the acquisition of additional robots can really serve as a springboard to case volume growth and many of the other metrics that we try to improve with minimally invasive surgery. It's just critically important that the operations teams, the boots on the ground, are aware of the strategies and the benefits of these approaches to make sure that we have efficient utilization of these robots. Robots are expensive, whether they're financed with AMP or with more traditional methods, and it's really just critical that they're used efficiently. To do this, we found it's important to have regular meetings. At Mayo, we do it at least on a monthly basis, and frankly, more often if issues arise. At those meetings, we include surgeon champions, and we ask those surgeon champions to assess patient populations, to evaluate demand, to look for new growth, to evaluate new technologies. And at Mayo, that includes representation from urology, gynecology, colorectal, general, thoracic, cardiovascular surgery, and also anesthesia, because they're all critical stakeholders in this process. We also include hospital administration so that they're aware and supportive of the issues that the clinicians are bringing forward. Nursing support is really critical for the boots on the ground support that they can offer. And finally, we found it really helpful to have dedicated robotic coordinators that are present to troubleshoot issues that may arise with scheduling, technology, and just support of the daily robotic practice.
Thank you very, very much. And Chris, let me ask you the question and then come back to Dr. Tollefson. You invest in a system, then you reinvest in the system, you're investing in the teams around the system. Talk a bit about that strategy and thoughts on investing and reinvesting in robotics and why it's become such a priority and why it works so well.
Well, I think it first starts with it, kind of going to Dr. Tollefson's point, is that if you just use traditional capital procurement strategies, you're never going to be invest fast enough to keep up with the need for access or having the ability to put the right tools in the right surgeon's hands when you need them. And so I really think it takes a lot to reinvest. We also went down the road of looking for alternative strategies so that we could get multiple robots here on our campus. It required a lot of work with the Intuitive teams to come up, and we use the accelerated MIS program, which we call the AMP program, which kind of allows us to do a more of a pay-per-click kind of model, kind of operationalize the cost. And I'll be able to do that. We're able to reinvest faster and be able to get the right equipment on our site and also make sure that we can advance the technologies as the technology improves, which it was also part of the driver to the evolution, is that the evolution of the technology.
And then it's really helped Sharp become a leader in robotic surgery and minimally invasive surgery, hasn't it?
Yeah, absolutely. And I think at this point we have over 28 robotic surgeons. We have 8 different service lines using the robots. And I continue to see lots of opportunity for that to continue to grow as we continue to see the advancements in the technology.
Thank you. And Dr. Tollefson, any specific metrics? You're probably the most elite academic medical institution in the country, one of the 2 or 3 most elite academic medical institutions in the country. Any specific metrics you look at from an academic perspective, a research perspective, anything you particularly look at?
Yeah, I think we really try to take a comprehensive look at our practice. So clearly the COVID era has hit certain parts of the country very severely. We've seen that use of our robotics platforms has reduced length of stay in the hospital, which has become a real premium. We've seen that it's reduced need for our patients to be in the ICU. We've seen a reduced need for just resource utilization overall, including blood transfusion rates and nursing resources on the floor. So we really view this as a critical component to our surgical practice overall. And really, our robotics practice has enabled our surgical practice to maintain its high volume and maintain its reputation.
And Dr. Bishop, you with Randy Ostra run one of the great regional systems in the country, magnificent system in Promedica. How have you moved towards standardizing this, moving towards it as a service line? What are some of the important tips towards doing so and some of your observations?
Well, I think you have to have buy-in at all levels of the organization. As I've kind of moved up in the organization, I've been able to now kind of lead that at the C-suite level. But we bring finance into our steering committees, into our service line meetings. We have tucked robotic surgery under our surgical service line, but it definitely has a subset with which it lives. And that is a robust group. It has all of our top performing surgeons that in multiple different specialties. It has the leaders of our operating rooms. It has buy-in from anesthesia. Again, it has the finance component. It has somebody at the C-suite level that's there able to make those capital decisions. And then we have really robust discussions, and we can try to be just as transparent as we can be with all of our data. And the great addition we have is we have the intuitive reps and the data analytics that intuitive can bring to us, and those people are with us as well. So we've really evolved as in our conversation. It's really matured. I think our relationship with Intuitive in general has gone from very transactional to being extremely cooperative, and we're really trying to row the boat in the same direction. And that's taken evolution both from the company, and it's also taken evolution from our leadership, because before it was a vendor transactional relationship that was difficult. So we've kind of created an environment, I believe, where we can put the big decisions in front of the group and have the decision makers make those decisions, and hopefully we can be more nimble. And by doing that, now, cases that may not be able to be done after 5 o'clock, they can get done at 5 o'clock, because everybody from the frontline staff and the OR to Randy Ostra knows that we want to provide the same level of care no matter when you come through our door. And that reducing open surgery is a goal that we all take value in and take pride in, because it's just the right thing to do.
I mean, it's really a fascinating perspective, Dr. Bishop, about sort of working hand in hand on the data side, a very interactive relationship to get better and better at standardization, isn't it?
It absolutely is. And I think transparency is the key, having open conversations. We're now asking every surgeon, if you're doing an open case, you need to justify why you're doing that open. And that's not a traditional conversation that people have with surgeons. But it does create the environment where your surgeons collaborate, they discuss. These are competitive people that want to perform at high levels. The more transparent you are, the more they ascend. And that's kind of our philosophy.
Thank you very, very much. And Dr. Tollefson, from an academic perspective, the benefits of standardization, any thoughts or observations? And then we're going to move quickly to site of care and payer strategies in a moment. But Dr. Tollefson, any thoughts around standardization, what you're saying?
Yeah, I think the benefit of standardization, I couldn't agree more with what Dr. Bishop mentioned earlier. I think we've tried to standardize our service lines. We've created pathways of care, which I think are really critical in helping to reduce some of these metrics of lengths of stay that we've mentioned. We've created pathways to create same-day discharge for colectomy. Our radical prostatectomy length of stay is now measured in hours rather than days. And I think these metrics have all really helped to advance the practice and reduce the resource intensity that our surgical practice needs.
And let me ask this question of you, Dr. Bishop, as we switch over with all three of you to site of care and payer strategy issues. Dr. Bishop, site of care, I mean, there's been so much changes in site of care over the last couple of years during COVID, during the pandemic, but even before then. Talk a little bit about how you look at site of care issues. Are you trying to be in an outpatient setting versus inpatient setting? How do you look at, in general, site of care issues and payer strategies?
So we have kind of a hub and spoke model where we have a tertiary care facility that does the bulk of our big cases and our more higher acuity patients. And as that hub continues to get bigger and bigger and work harder and harder, we had to decant many of the outpatient procedures outside that. So that was a process that we were already kind of working on. With COVID, everything accelerated and the world changed. What we were able to do, and with the help of our Intuitive partners, we actually moved one of our XI robots over to an outpatient, actually an orthopedic spine hospital. And we kind of made that, for lack of a better term, kind of our clean hospital. And we continue to do all of our cancer patients there, a lot of the GYN oncology patients could be taken care of there. We really utilize that robot at a really high level to maintain that care. So, we have about 17 robots in our system right now. We work with Intuitive regularly on how we deploy the systems that we have. We have X and XI systems. And, we have a great relationship that allows us to be a little bit more nimble. And, we have to continue to decant cases to those ambulatory and outpatient settings where they make sense. And, when you start talking about measuring length of stay in hours, we're living that every day, and that it is driving everything towards the outpatient surgical areas. And so, we're seeing XIs in outpatient surgical areas. That's because it just makes a lot of sense. So it's an exciting time to be part of that, and I'm really proud of our team that gets up thinking about this every day.
I mean, it's really an amazing leadership perspective from a robotics perspective. 17 robots, magnificent program. Dr. Tollefson, let me turn to you. How do you look at site of care issues? How has that changed over the last, 18 months or so? A couple thoughts there.
I mean, it's clearly changed. And we've had a similar experience to what Dr. Bishop mentioned earlier. We did an analysis of our own practice and found that almost 40% of our robotic cases were performed as an outpatient. And, that insight really led us to recognize that our outpatient surgery center was really an ideal location for one of our XI robots. So we also transitioned one of our XI robots to that outpatient surgery center to help facilitate the procedures that we can be done as an outpatient and really support those patients in that practice as best we can.
Oh, so just magnificent. Thank you. And Chris, your thoughts on sort of a couple things, how this has moved, site of care has moved and changed and what you're seeing there. And then also capitated strategies, other strategies, how this plays into sort of your managed care strategies too.
No, absolutely. We have the same experience as Dr. Bishop and Dr. Tollefson. We realize that we have a pretty fair amount of outpatient surgery. I think over the last 10 years, the biggest growth in robotic surgery has been in general surgery. And a lot of that is really outpatient type care and can be outpatient. So we took one of our X robots. We had a couple of X platforms. We knew that we really needed the XIs in our tertiary ORs. So we moved the X robot over to our outpatient Pavilion, which is on our campus. We started doing a lot of general surgery, and we're working on a second robot moving into that setting as well. We've already done some piloting of flop rooms where we kind of have a surgeon going back and forth on these quick cases between two robots, just testing that strategy to see how do we create the most efficiency, how do we really try to drive the cost down. And that's where robotic strategy and capitated kind of come together. If you can create the lowest cost setting to deliver a high level of care that requires a very low length of stay, very minimal complications, and very low pain for our patients, you can also create a better experience for your patients as well, because the outpatient surgery strategy is certainly a whole different experience for the patient as opposed to coming into the hospital for care. That fits right into our capitated care models, where we are continuing to try and reduce length of stay, reduce total costs, and try to make sure that we have member satisfaction with that care. But to do that, you need access. You need to be able to get on the platform. You need the capacity to handle that volume.
I mean, and it really ends up being great efficiency, great standardization, great surgeons, great staff, and then a great partner and Intuitive to make sure you've got all the information and data and things you need to make this work and make the investments and make it better and better. Simply fascinating. We're going to give each of you a minute or two to talk about what you see as the surgical line of the future. What does surgery look like? A couple of your thoughts on that. I'll start here with Dr. Bishop, and then we'll go to Dr. Tollefson and to Chris. Dr. Bishop, what are your observations? What do you see over the next couple of years, next 5 to 10 years, as surgical services lines sort of improve and grow? What are some of your thoughts?
Well, I think, as Dr. Tollefson said, a lot of our people come out trained in robotic surgery, and they want to work in areas where they can continue to master that craft. And so I think robotics, first of all, if anybody's question whether it's here to stay, I mean, it is. It's affecting recruitment. It affects, acquisitions. It's a huge driver currently. I think in the near term, we're all going to get to the point where we've got to be able to provide that level of care pretty much 24/7. And that takes tremendous buy-in from anesthesia. It takes tremendous training for your staff. It takes physician champions. It takes leadership in order to make that happen. But I think people deserve and should demand that long term. So we need to get ready for that. So I think that is a short-term evolution that you're going to see, that some of the cases that people may do really well between 9 and 5, they're not doing after 5 or on the weekends. I think you're going to see that evolution. I think long term, the robot and minimally invasive surgery is the way to go. It is ultimately going to be demanded by payers. If you're not delivering that level of care, then that level of care is not going to be probably performed in your institution. It's going to go elsewhere. That's just going to be driven. And I think that's what we all have to understand. And then the really great evolution is to be able to take the technologies and then really maximize the efficiency that the technology can really bring. You might have less people necessarily have to be with you in the OR. You might have, again, the length of stay issues are markedly improved. But you can kind of see how the technology continues to get better. The people, these really talented people, are using that technology, and they continue to find ways for that technology to grow. And I'm not a real visionary, but I'm excited that I know I'm going to be able to watch it. And I know it's going to happen. And I know that this cat is out of the bag. It's an exciting time in robotic surgery and minimally invasive surgery as a whole. And that evolution, you're going to have these kind of conversations with people much smarter than me over the next 5, 10, 15 years.
Dr. Bishop, so many things you said resonate so well. One of the things you said that's so important is residents and fellows coming out expect this. They want this, and more they're trained in this, particularly in a whole bunch of specialties. They would think that they're not going to come to a system unless you have these kinds of assets and opportunities for them. So that is so important, too, in terms of driving this forward as well. Thank you very, very much for your comments. Dr. Tollefson, your thoughts. What does the surgical service line of the future look like? Some of your thoughts here around that in robotics.
Well, I think I'm so excited with what the future may bring here. I think, as has already been mentioned, we'll continue to see residents and fellows and surgical trainees come out expecting robotics, expecting to be able to offer these to their patients. But I also look at what the next generation of robotics can mean, how augmented reality can help us see what we can't currently see, how we can use artificial intelligence perhaps to evaluate surgeons, to evaluate surgical techniques, to do things that we're just not able to do right now with our traditional systems. So I think that there will be clear growth in the near term, but I also feel like there is such an opportunity and such an amazing time here that we'll have in really computer-directed surgery as much as robotic, that I think this will really change the paradigm that we have in surgery, and potentially not just to try to equal open surgery results, but to meaningfully improve cancer recurrence rates, to meaningfully improve surgical techniques. I think there's a real opportunity, and the next 10 years are going to be just an incredibly exciting time in this area.
Your point is well taken for a whole variety of reasons. Aside from cost, standardization, everything else, this is going to lead to better outcomes as well, and already is. But you see an acceleration of better outcomes for all kinds of surgeries as people invest more heavily in digital surgery and robotics and so forth. I mean, Dr. Tollefson, is that a fair assessment?
Yeah, no, I couldn't agree more. I think as we as a society, as we as surgeons start to digitize our surgery even more and more, this will fundamentally change the procedures that we do now, and it will improve outcomes for patients reaching into the future.
Thank you very, very much. So helpful. Thank you. Chris, Sharp Memorial, Sharp Health System is an incredibly competitive part of the world in terms of healthcare. Sharp has used the robotics program to sort of lift itself up as a part of the fabric of Sharp, magnificent system to compete in a very competitive market. Talk about what you see as the clinical service line of the future, the surgical service line of the future, and how Sharp continues to extend its leadership here.
Yeah, I think the technology is just going to keep advancing. And I think my joke with my surgeons is the next version is going to be the ZI, and then the version after that will be the AI, and then we may not need them anymore. And so, although we know we'll always need our surgeons, but that's my joke with them. But in some form, there's going to be some kind of robotic or navigation or advanced visualization that's going to be occurring. So minimally invasive will continue to spread. Robotic surgery will continue to expand. And it will be in every room in some form over the next several years as we move forward.
Thank you. And Chris, to your point, I've heard great and magnificent surgeons say, this doesn't replace me. This makes me better at what I do. And I think that's very much the mindset. The robotics isn't going to replace them. It's going to make a good surgeon better. It's going to make a great surgeon better. It's just going to give great surgeons more tools to better see the patient, to better understand what they're doing with the patient, to get better outcomes. And it's a fascinating perspective because there always is that fright. What does this mean to the surgeon? But really, for the surgeon, just a tool to make them immensely better and better and to let them do their very best work. I want to thank Dr. Bishop, Dr. Tollefson, Chris Walker. What a pleasure to visit with the three of you on robotics and surgical service lines. I want to thank, obviously, Intuitive 360. What a magnificent investment they've made in this world of robotics. Thank you, folks, all for joining us today. What a pleasure. Thank you very much.
Thank you.
Thank you.
Thank you for having me.